We are starting now our session on the WHO Global Initiatives on Cancer, bringing together stakeholders from around the world. Our chair today is Dr. Partha Basu, the head of the Early Detection, Prevention and Infections branch here at IARC. And I will now give you the floor, Partha, and I will just ask participants and viewers on YouTube to write their questions in the chat. We will take questions after each presentation of our contributors today. Partha, the floor is yours. Thank you.
Thank you, Sandrine. Dear participants from across the world, it is my great pleasure to welcome you to the third of IARC Summer School Public Event Series. So today's session is titled The WHO Global Initiatives on Cancer, Bringing Together Stakeholders from Around the World. As you know, cervical cancer, in spite of being highly preventable through a combination of vaccination against human papillomavirus and quality assured screening, kills more than 300,000 women across the globe every year. And nearly 90% of these deaths, they occur in the countries with limited resources. So this highlights the global inequalities in accessing affordable and high quality preventive healthcare services for cervical cancer. The number one cancer among women across the globe is breast cancer. But the good news is that the treatment of this cancer has not only become more effective, but also less aggressive if the cancer is detected at an early stage. Unfortunately, there is a huge disparity across the globe. In many high-income countries, the 5-year survival from breast cancer is 80% or above, as most of the cancers are detected at an early stage and managed. But then this is not the case in low and middle-income countries. Death of a woman at her prime age from cervical or breast cancer has huge social and humanitarian consequences. Our colleagues at IARC, they have demonstrated that every year more than 1 million children become maternal orphans due to death of women to cancers globally. And cervical and breast cancers are responsible for nearly half of these maternal orphans. Considerable inequalities between populations and degree of socioeconomic development is also noted in survival for childhood cancer, with substantially lower survival rates seen in most LMICs compared to the high-income countries. In the high-income countries, the 5-year survival of childhood cancer overall has improved from 30%, say around 1960s, to more than 80% nowadays. Good quality survival data on childhood cancer is rarely available in the low and middle income countries. However, if we take mortality to incidence ratio as some indication for survival rates, we see that the ratio in Europe is lower than 20%, signifying quite high survival from childhood cancer. In Asian countries, this same ratio can be as high as 50%. So the global actions are needed not only to provide guidance to countries on how to improve cancer care, but also how to handle the social and structural determinants of inequities. And that is why the WHO has launched 3 global initiatives: Cervical Cancer Elimination Initiative, Breast Cancer Initiative, and Initiative for Childhood Cancers. Today, we will hear from the experts in the WHO who are providing leadership to the planning and implementation of these initiatives from the WHO. It is my pleasure to introduce Dr. Nashwa Skaik, who will be speaking on the WHO Cervical Cancer Elimination Initiative. Nashwa is an obstetrician and gynecologist in her background. She is currently the technical officer in Cervical Cancer Elimination Initiative in WHO. She is interested in capacity building, quality of care, and best practices. Nashwa has worked previously in managing complex women's health problems in emergency in the Eastern Mediterranean region, including mental health. Nashwa, the floor is yours. Thank you.
Thank you very much, Dr. Bartha. Give me a moment to share my screen. Okay. Is it possible that someone can confirm that you can see my screen?
Yes, we can. You just need to put it in presentation mode. At the bottom.
I see it in presentation mode from my side.
Maybe you need to change the window that you are sharing for the presentation mode. If not, it's fine like this. That's it, a bit bigger.
I don't know what to do better.
Maybe go back to where you were before, unshare, and then share again the.
Go to display settings
Yeah.
up at the top. If you can go back to that window that you had, that was right. And display settings, it'll toggle to the presentation mode from the presenter mode.
That's it. Perfect.
That's perfect now? Okay.
Yeah.
So thank you very much, Dr. Partha, for the introduction and the great team and IR for organizing this. It has taken a lot of time and preparation and effort. So thank you very much for including me and my colleagues here. So I'm Nashwa. I will present some information about the WHO Cervical Cancer Elimination Initiative, the work that we're doing, and I'm very happy to receive all the questions at the end of the presentation. And please feel free to share your thoughts. The outline for today's presentation is I will highlight some information about the burden of the disease, inequities, especially among vulnerable groups affected by cervical cancer. After that, I will present the response of WHO to this burden and the call for action from Dr. Tedros. Following that, I will present the norms and standards and the technical product that we produce, what kind of country support we offer, and how we support implementation. After that, I will speak a little bit about the role of leadership of WHO in the initiative, and then we can see what is the way forward, and I'm looking forward to receiving the discussion and questions from the audience as well. In this slide, I will present the latest data on the burden of the disease. So cervical cancer is the only cancer that could be preventable and curable. And every year, there are thousands of women dying of this disease that can simply be prevented by simple, cost-effective, evidence-based measures. Also, I would like to say, if I'm using some technical words, feel free to ask me what does that mean. I'm happy to answer that. So in 2020, which is the latest published data that we have, almost 340,000 women die of this disease. And if you look at this map, you will find that most of them are in places that are already vulnerable, already suffering from other crises. You will see parts of Latin America, Africa, and parts of Asia. And that actually show how the burden is actually distributed in specific countries around the globe, and that's actually due to many other players that we will talk about as well. In this map, it shows also the incidence, how many new cases are discovered cervical cancer every year. And you still find that new cases are found and discovered every year in the same similar disadvantaged places where there are a lot of vulnerable population and high burden of HIV as well. Why I'm talking about HIV? HIV, it's known and documented by evidence that it has a lot of comorbidities, and one of those is cervical cancer. It's found that cervical cancer happens 6 times higher in women with HIV than about the general population. And it's something that we need to keep in mind as program managers on how actually to target this population who have high burden of the disease, how to use the platform that offers services related to HIV as well. Responding to that, Dr. Tedros have called for action in 2018. He says 1 woman dies of cervical cancer every 2 minutes. Each one is a tragedy and we can prevent it. Luckily, in 2020, WHO has launched the global strategy to eliminate cervical cancer as a public health problem, and member states have endorsed that in the resolution in the World Health Assembly. So now we as a global community within the public health domain are responsible for this agenda. We should work together with member states to eliminate this cancer from history. Following this launch of the strategy, which you can see here at the beginning of the arrow, it comes a lot of work related to technical products. Technical products, norms and standards, it's a term that we refer to the technical documents that we produce, the evidence-based guidelines and the guidance that we publish and distribute to all around the world for people to use, adapt to their own context, and hopefully help in implementation. So from 2020 to until now, actually, whole department and different departments within the WHO produce many evidence-based information that hopefully can update the already existing guidelines and support countries. Last year in 2022, the 6 regions of WHO have adopted a framework for action to eliminate cervical cancer. It's a more contextualized guide that tells and advises member states what they should actually do in order to be able to fight this disease. Now it's the time for implementation. So what we can do as WHO, and also with you, with partners, and with people all around the world, and stakeholders who can help in that. The global strategy have an ambitious goal to reach only 4 cases per 100,000 women diagnosed with cervical cancer. That's the threshold that we would like to reach. How we can reach that? Through a simple, cost-effective, and evidence-based intervention that are of high quality and help assist in eliminating the disease. 90% of girls must be fully vaccinated with HPV vaccine by the age of 15. And 70% of women between 35 and 45 should be screened with high-performance tests. And what mean based on WHO guideline, it's HPV DNA test. And we can talk about that later. And then 90% of women who are identified by pre-cancer disease out of the screening or identified having invasive cancer should be treated with quality care. And this continuum of care along the life course of woman, since she's an adolescent or girl until she's an adult, this is called a comprehensive approach across the continuum of care. And this is the way that we tackle this problem. You cannot tackle this problem by single intervention, actually. In this slide, I would like quickly to highlight the WHO program of work. How WHO in general, the mission, we arrived to our mission, which is actually promoting health and keep the world safe. We do that by reaching the 3 billion of population around the world. And that's actually by intervention related to promoting health, universal health coverage, and addressing emergency. The work of cervical cancer actually work mainly on achieving universal health coverage, but that doesn't mean that we also cross-cutting across other pillars. So we work together within WHO under something called strategic shift. So it's a comprehensive area of work that includes global goods, which is technical products and guidelines and evidence, also policy, dialogue, and leadership, which is an important role for WHO in the scope and ecosystem of global health. And that actually comes with a special organizational shift. But I just would like to highlight this general framework of WHO. So if you want to ask me, so what actually WHO at this stage advise government to do? These actually some points here that highlight what is our vision, how we envision this strategy translated into action. So what we see first, and quickly here, I will mention that as WHO, we advise government, WHO at all levels, partners, to work on the national policy to eliminate cervical cancer. That's actually one of the most important things that highlight political commitments. And following that, we can scale up to national strategic plans and reach universal health coverage within a country context and adapted system. Actions also should be customized by country, taking into consideration all the level of readiness, the level of implementation that they can reach, factors that can play such as social demography, religion, gender, a lot of things related to myths and misconception that actually hinder the development of cervical cancer and other cancers and maybe other diseases within the context of community. Also addressing inequities in health, and that's something that we always keep in mind to reach those vulnerable, including people who live in poverty and other comorbidities such as HIV. And the other thing is that cervical cancer programs are always should be situated in a holistic approach. It's never a vertical program. We don't work alone, but rather we work with other colleagues in cancer. We work with other colleagues in NCD. We work with other people as stakeholders in sexual and reproductive health, and also advocates and engage people, patients and people who have been affected by the disease. And of course, I've mentioned that our engagement and leadership with key partners on the ground is something that's so important because we're not the only players and we are not the main implementing partners as well. There is a lot of civil societies and people on the ground who understand the context and who can help us move this forward. WHO work across the strategic shift for cervical cancer, as I've mentioned, comes under three main pillars, and these are our work in norms and standards and products, our work to support countries, and also an important role in leadership. And now in the next slide, I will explain exactly what I mean by each of them. Here, that's quite a busy slide, and I will invite you to visit the website for Cervical Cancer Elimination Initiative on WHO to see what I mean by technical products. So this is a simple roadmap of what the team within WHO and key stakeholder and partners who collaborated with us to produce the specific amount of technical products that covers a wide range of areas that we believe should actually tackle the problem and help countries address the issues and the challenges and gaps. However, these products are global, and it has been made and with the aim that countries have to work with partners, stakeholders, and academic institution and expertise, especially the local expertise, to translate these into their own context. And that's an important part to scale up and push implementation. These products have been, I only actually have a snapshot of products that have been published from 2019, just before the call of action until 2023. But it's not the first time that WHO work in cervical cancer. There have been always a lot of guidelines, but we keep updating them and we keep informing about the new actions that we take with partners and governments. So I really invite you to visit that, see what kind of products that we cover. We have a lot of things related to vaccination, to screening, invasive cancer management, a lot of general globalized framework, but also how to implement things. So you will find also guides on how to do things. There is also a monitoring and evaluation framework that should help government measure themselves and understand their progress. You will also find products from the regions as well. Here, this is a snapshot of the monitoring evaluation framework. So if we have a strategy and we would like to eliminate a disease, we need to have a roadmap. We need to measure ourselves. And this is actually the standard where all countries all over the world hopefully should measure eventually by improving service with time. Country support that we offer, we have supported until now 20 member states. But that doesn't mean that we only focus on 20 member states. You will see them highlighted in this map. But rather, we welcome any country request in their own strategic country support plans. We discuss with regional offices, country offices, and HQ. So it's a 3-level discussion. And also we include members in these discussions, such as, for instance, IARC, who are hosting this event, play an important role in many activities, including assessment and tool development and research and data. So this is just a highlight of the work that we're doing in countries, or what countries that we actually support. But definitely political commitments, engaging community is 2 things that we consider highly strategic in our engagement. How we engage with countries, if we want to ask this question, how we actually support. The sample of country engagement actually comes from looking for policies, national cancer plans, NCD plans, universal health coverage plans, sexual reproductive health plans, or if they have a national plans for cervical cancer. We understand the priorities, we understand the burden of the disease based on situational analysis, and following prioritization of what is needed in these countries, we start a scale-up implementation plan with country. We bring partners together, we sit with government, we look at ways in improving data, measuring, capacity building. So we work across the health system and take action together. And following that, we encourage measuring and review and reporting based on the monitoring and evaluation framework that we have. And IARC has a major role in that because they work and they have a lot of work probably everybody is aware of on cancer registries and improving data collection and research. Some information about the progress that we have made so far. This is a quick revision of the vaccines that have been approved. There are 2, the last ones are still in process for HPV vaccination approval process. This also show the coverage of immunization all around the globe and how many countries in 2023 have adopted and included HPV vaccination within the immunization plans. Some of you might have heard about the 1-dose policy and that it comes with some recommendation from different entities, including Gavi. And these are a list of countries who are adopting or planning to adopt 1-dose policy. HPV screening, these are the tests that are qualified by WHO. It could be useful for some people who are helping implementing that. And this is the latest map published of a study that is referenced here, and it shows the number of countries who have been introducing HPV vaccination. Usually, it's not the first introduction. You can see Australia as one of the main leading countries, but many of the countries around the world, especially middle-income countries, have a hybrid form of screening. And so it's not the main, usually, HPV screening, but I can mention that around 20 countries around the world use HPV DNA screening right now. But unfortunately, we still see many of the unfortunate low middle income countries actually don't use that yet. So there is a lot to do still. Leadership and implementation, as the initiative has an important role in coordination. So we work with UN agencies, UNFPA, UNICEF, and we also work with our sister agencies, IARC and AIA. We produce documents together, we review, we go to missions, we have continuous collaboration. Also, partners network, implementers network is something that we would like also to strengthen more in the future, to continue our dialogue with stakeholders. A lot of advocacy and high-level events that our leadership participate in, and it's an important role that even Dr. Tedros is very keen to continue with that. So we have now WHO ambassador from Henriette Lacks family, and 17th of November is always a day of action where highlight some of the country's progress, and we call for partners to come together to support. We are keen to create a platform, hopefully through the Knowledge Action Portal in the NCD, to share knowledge and lesson learn between countries. And that's something that is, we believe, is so important to encourage countries to learn from each other and adopt and contextualize some interventions into their own context. And something also WHO, one of the mandate of WHO. We include advocates and survivors and people who lived with the disease. Last few slides here, because I would like to have more time for questions. WHO leadership is a flagship, and it's one of the main 5 strategies is that WHO should be the lead in the global health domain with other partners, stakeholders, and governments to align the agenda. And it's one of the main 5 priorities for Dr. Tedros. We call all partners and multi-sectoral dialogue to improve and make products available such as vaccination, thermal ablation, treatment, and screening products that we advocate for. We will work together to unify reporting, especially report of progress and indicators, and we will continue to support countries to contextualize solutions and have a dialogue with countries to see what actually works and what doesn't. Thank you very much. Here I just linked the link to the initiative, and I welcome all the questions. Thank you very much, and the floor and the mic is back to you, Partha. Thank you.
Thank you so much, Nashwa, for this very nice presentation. I'm sure there will be quite a lot of questions from the audience. While we wait for the questions to come in, maybe I can start with a question to you, Nashwa. You know, the strategic document, it stipulates this 90-70-90, target for the countries to achieve by 2030. Where from did this magic figure come?
Oh, so a group of experts in the beginning, when after Dr. Tedros had called for action, these figures had come from modeling exercises and to understand what actually is available and what is achievable by 2030. These interventions that are used are evidence-based, and they have already studied that says the efficacy of these things, the HPV vaccination, HPV screening, what is the success rate, what is the efficacy, and looking at these numbers and these data eventually can give us an estimation of how much we could cover if we use these effective interventions right away. It looks really ambitious, and I understand your questions, but we should work together and accelerate implementation. But this is how things have been calculated. Yeah. Indeed,
to get the cancer eliminated by end of this millennium, we need to work together to achieve these targets.
Yeah.
Now, there are a few questions. One question is from Athanase from Rwanda. So her question is whether the WHO recommends HPV vaccination for both boys and girls or only for girls?
That's a nice question. So there is WHO have published in December 2022 a position paper, and I invite you to read that. I can share the link with the organizers, and they can share it with you. for the vaccination is actually safe and recommended for everyone. But if a country and a government has to choose and make a decision on which group of people should be vaccinated, that should come out of epidemiological understanding of the distribution of the disease, a financial situation, and the context of the population where we are talking about. So, because there's a lot of the discussions about the price and the cost of the vaccine and how it's really cost effective and how it's efficient. So we support gender neutral vaccination. However, if the country is unable to offer that for financial situation, we recommend that country focus on vaccination girls while transitioning into vaccination boys at a different stage. And that's because the immediate effect on protection for girls is so important because cervical cancer happens to them, but that doesn't mean that also other type of cancers happen to boys. And that's why we recommend a gender neutral vaccination. However, that really depends on the context and situation of the country. So if you want to kind of draw a prioritization map, you will first think about the girls. You should think also how many doses the government decide to give. 2 doses or 3 doses usually are recommended, especially for vulnerable population with HIV. But a country now can look into the feasibility of 1 dose. And maybe if they take that approach, they can spare some doses for men, for boys. And thinking this way could help the country make the decision.
Thank you, Nasha. I think we can take a couple of more questions. So there is a question from Ishaq Lawal, which is, what support system is there for stakeholders in LMICs to have access to equipment for treatment, particularly for leads or obtaining biopsies?
So what does it mean, stakeholder? Maybe she means facilities or...
Is there any support from the WHO or any of the global stakeholders that the countries can look forward to?
So we advise any country to go to their own country office as well and regional office. Usually they will have a database on what are the recommended procurement channels, what are the recommended prices. Also, UNICEF has published a tool. So if these countries can procure some equipment through UNICEF, they can also support them with that. However, WHO at a global level, we are leading dialogues with many manufacturers, private sectors, and people on the ground to negotiate what are the available products, what are the prices, to make things more available for government and accessible. So if a country would like to look into things, I advise to go to the country office in the country and request, if they have a specific request, the HQ always happy to facilitate this discussion. And that's actually what the WHO usually do.
Thank you, Nasra. There is a question from Sophia Azib about the LMICs. Many LMICs will find the HPV detection test to be not yet affordable. So what will be the message for the countries who have introduced VIA and currently using VIA as the screening test?
So in our strategy, what we are looking for is that something that is high quality, that gives very accurate result, sensitivity and specificity wise, and also is cost effective. And based on this strategy, if we looked at that, I understand that countries have done so many work in VIA or cytology. However, if you look at the whole, because we are not looking only at the tests, the thing is that sometimes we keep our mind constricted in a place where the test is expensive. However, a screening service is actually across different layers. So you have a test, you have a laboratory, you have pathology, you have another visit that women should come maybe. So looking at the whole cycle of the screening, eventually you will find HPV DNA is actually cost effective and more affordable when compared to VIA. This is one point. The second point is that based on the WHO guidelines, VIA can still so far use in triage tests, especially for women living with HIV. And also maybe some countries would still, for other reasons, whatever, use it for the general population. So VIA skills and the infrastructures that have been built is still important and should be leveraged. However, that should not eliminate the fact that we call for the piloting, understanding HPV DNA constraints, and overcome these constraints, because eventually it has high specificity and sensitivity, it's more accurate, it's cost effective compared to VIA, and it's more comfortable for women, so you ensure that the follow-up is not lost. All of these should be kept in mind, and I don't want also to forget that VIA has created an environment that enable the screening services, and I encourage that we use that to introduce HPV into scale.
Thank you, Nashwa. And VIA will be very useful in triaging the HPV positive women. So that
Exactly, that's another point. Sure.
There is a question, comment and a question as well from Mirza Muhammad from Pakistan, I understand. I think how they're saying a comment is, I think cost of HPV vaccine is one of the major reasons why it is not included in the National Immunization Program in LMICs. Question is, what steps can be taken to overcome this hurdle?
Okay, so and even Pakistan, I know that Pakistan is still in the early conversation stage to include HPV vaccination. So I wish them all the best. The main steps to start introducing and thinking about the introduction of HPV, first of all, you have to understand the burden of the disease in your area. You have to understand the accessibility and the feasibility. But also you have to go and negotiate and speak to the right people. So the government bringing in all the partners such as Gavi, maybe some donors such as Gates, anybody who is has a strong presence could actually help you to start building your own national program and start the introduction. Especially low middle income country who have funds who comes from Gavi. Maybe it's different for some other middle income countries where they find it actually difficult because the funds are not available. But we all know that eliminating this disease at the long run is way much cost effective than thinking about just the vaccine cost. We have to look at the whole programmatic cost. And that's my advice that I will give to any country that would like to start introducing HPV vaccination.
Thank you, Nashwa. I think we can take one last question. That is there a package from WHO, especially on chemotherapy drugs, radiotherapy access at country levels for treating invasive cancers?
Another good question. So for radiotherapy, we have mentioned that we work with IAA, and what we have been working on is understanding the feasibility and access to radiotherapy. What are the challenges to accessing radiotherapy? So understanding this information will help us give the right information to government so they can tackle these challenges. And that attract also funding and investment in some areas to make radiotherapy available for women. And also we have worked with IAC, just actually released, I think in February, a document on what are the specific therapy that needed to treat cancer, including cervical cancer. So I invite you to look at that as well. Chemotherapy, we have a framework for managing invasive cervical cancer disease. It also guides you to the proper channels and guidelines that you can look at. So you can look at the chemotherapy options. Not only that, but also surgery. Now we are working to increase capacity for oncological surgery. So the invasive cancer management is something that we keep in mind. I don't say that we are still there. So a lot of things needed to do, but maybe more advanced in radiotherapy domain than others.
Thank you so much, Nashwa.
Thank you, Dr.
Now, there are more questions, but then we'll keep them for if we have time at the end of all the three talks. So it's time to move on to the Childhood Cancer Initiative. And it's my pleasure to introduce Dr. Roberta Ortiz, whose expertise is collaborative clinical research initiatives in the field of pediatric solid tumors and supportive care, and provision of technical support for cure-all implementation across the WHO 3 levels. Over to you, Roberta.
You need to unmute yourself, Roberta.
Thank you so much,
Thanks.
Partha, for the introduction, and thank you, Sandrine. I'm just trying to share and to see if you're able to see my screen.
You just need to put it in.
Okay.
Yeah, present mode.
Is that the right one? Okay, thank
That's
you very
right.
much.
That's
So
better.
thank you to our colleagues in IARC for allowing us this opportunity to share with you today the integrated approach on cancer global control through the WHO initiatives. So in my presentation today, I will include a brief background on the Cure-All operational approach, which is the Global Initiative for Childhood Cancer Framework for Action. I will then walk you through some examples of the progress that has been achieved in the past 5 years into the implementation, and also share with you the progress both at local, regional, and global level that have allowed to consolidate the impact of the Global Initiative for Childhood Cancer, and share with you also new opportunities on how to engage and new projects on the way. So we know that care for cancer, like many other diseases, reflects inequalities and inequities in our societies, but the impact on children is devastating. Each year, approximately 400,000 children around the world are diagnosed with cancer. Most of these children, as Partha mentioned in the introduction, live in low and middle income countries where treatment is often unavailable or unaffordable. The burden of this disease is heavy and the access to care is uneven. There are several factors responsible for the inferior survival in children with cancer diagnosed in low and middle income countries. Among these, the most relevant that we have identified are missed opportunities to diagnose due to the lack of expertise, delayed diagnosis, high rate of treatment-related mortality linked to the lack of adequate supportive care, and abandonment of therapy. Inclusion of childhood cancer as a public health priority is feasible, effective, and sustainable. It offers an important opportunity to catalyze progress in cancer control and to demonstrate success in the non-communicable disease agenda. The recognized factors that we previously mentioned for low survival in non-middle income countries are reversible with system-based interventions that increase access to care by improving diagnostic capacity, creating more efficient service models through strengthening referral pathways across levels of care, optimizing workforce competencies. As an output to the Resolution 7012 on cancer prevention and control in the context of an integrated approach, WHO received a clear mandate to provide resource-stratified guidance for the development of cancer control programs, specifically calling for the inclusion of children and adolescents in the design of these programs. So the World Health Organization, alongside St. Jude Children's Research Hospital, launched back in September 2018, the Global Initiative for Childhood Cancer. In a side event during the General Assembly and the third high-level meeting of the non-communicable diseases in September 2018. So understanding where a child lives should not determine his or her capacity to survive. The Global Initiative for Childhood Cancer aims to increase survival rates for children across the world to at least 60% by the year 2030, while reducing suffering for all. This ambitious target will be achieved through a health system strengthening approach, which is the Cure-All Framework for Action, which will guide the policymakers and program managers by outlining specific key interventions that are known as the 10 Cure-All Core Projects, which allow countries to scale up their capacities to provide quality services for children with cancer and contribute in this way into the formulation of national policies and plans and to advance into implementation and monitoring for improvement. Here we can see the acronym of the Cure-All Framework for Action, and currently on the road to achieve the initiative targets, more than 70 countries across the 6 WHO regions are implementing the Cure-All Framework based on the 4 pillars that you see here and the 3 enablers represented by the acronym Cure-All, which includes centers of excellence and care networks that are fit for purpose with sufficient and competent workforce to increase the capacity to deliver services, accessing universal health coverage for essential quality service, regimens and roadmaps for diagnosis and treatment that are context appropriate and facilitate delivery of quality service through evidence-based use of essential technologies and medicines, evaluation and monitoring with robust information systems and research to ensure effective implementation. These 3 pillars are supported by 3 cross-cutting foundational enablers, which are advocacy, leverage financing, and linked governance. The framework supports comprehensive policies, access and coverage of services, and quality health systems for sustainable care. So in the next slides, I will walk you through some of the local and regional progress in the implementation of the Global Initiative for Childhood Cancer. In almost 5 years since its launching, the Global Initiative for Childhood Cancer has demonstrated that improving quality of care and outcomes for children with cancer is achievable through broad political commitment, strategic investments, and development of strategic action plans, which are led by governments and supported by multi-sectorial partnerships. Currently, 72 countries, as recently Egypt has also been engaged while I was preparing this presentation. So 72 countries are advancing in different phases of country action, from completing initial assessments of the or snapshots of their capacity to provide services for children with cancer, to planning and costing their national cancer control policies that are inclusive for childhood cancer. And here we can see a list of different countries advancing in the implementation of the pillars of the Global Initiative for Childhood Cancer. Here, I wanted to share with you a recent evaluation that was performed in December with the participation of 20 out of the 31st focus countries that are actively implementing the Global Initiative for Childhood Cancer. So in the past almost 4 years and a half, through the partnership with St. Jude Children's Research Hospital, WHO has provided more than $11.5 million in support to countries to advance in the implementation. During this recent assessment that I mentioned to you, we have seen that out of the 20 countries, they have strengthened the capacity to provide quality service for children with cancer through the implementation of the Cure-All Framework for Action, benefiting more than 37,000 children newly diagnosed, accessing care at the centers of excellence. WHO at its 3 levels, in collaboration with implementing partners, are contributing to provide intensive support to countries across the 6 WHO regions for active implementation of the 10 core cure projects. This is that you see reflected here on the left of the slide. This has contributed to advanced implementation, promoting equity in the delivery of care for children with cancer by establishing centers of excellence for childhood cancer care, expanding coverage through the inclusion of priority and cost-effective interventions for all children with cancer into essential health benefit packages, developing national standards of care for the management to guarantee reliable supply of quality medicines and devices, and also strengthening information systems for evaluation, monitoring for progress, and informing policy, and also, very importantly, promoting innovation and research. Here you can see that in the past 2 years into the implementation, great progress has been made in line with Objective 2 of the initiative, which calls for the increasing prioritization of childhood cancer into national policies and programs. More than a dozen countries across the globe have included childhood cancer in the formulation of their national cancer control strategies and plans. Also, as Nashua was mentioning, the identification of cost-effective interventions and generation of investment cases are important elements on the mandate provided by Resolution 7012 on cancer prevention and control, and are essential to progress into the realization of universal health coverage. WHO at its 3 levels is providing countries with technical support to inform cancer control planning through priority setting and cost analysis of their national cancer control policies, providing the national policymakers with options to obtain the best value for money in health spending on cancer by identifying and costing priority interventions that need to be included into the national cancer planning, by designing or updating cancer interventions that are currently included in the national benefit packages, and by supporting these governments to generate investment cases. In alignment with the Objective 1 of the initiative to improve the access to quality care for children with cancer via patient-centered efforts, many countries are advancing with the development of their national standards and guidelines for the 6 index cancers that are prioritized by the Global Initiative for Childhood Cancer. Here we can see some examples from Jordan and Pakistan. At the global level, we are completing a global guidance provided by the Cure Technical Package that was launched back in 2021, developing technical briefs for each of the 6 index cancers, which will support policymakers to identify those priority interventions aligning with the Universal Health Compendium that need to be included in essential benefit packages to improve delivery of service, but also progress toward universal health coverage attainment. Another example of the Cure project, which contributed to implementation of Pillar C, is strengthening the quality of the childhood cancer workforce to deliver services for children with cancer. Here we see examples in Yemen and Pakistan of the implementation of training packages in pediatric oncology for nurses. Now, to almost finalize my presentation, I would like to share some of the ongoing projects aimed at potentiating the impact of this collective effort that has been achieved almost in the 5 years into the implementation of the initiative. The Knowledge Action Portal that was also mentioned by Nashua on NCD includes or hosts a Global Initiative for Childhood Cancer Community of Practice. This community of practice has recently been revamped or updated, and it's part of the package of tools that supports the implementation of the Global Initiative for Childhood Cancer. In the Knowledge Action Portal, you can access through the Knowledge Repository a series of technical products or documents that can assist through the implementation of the Childhood Cancer Initiative, but also to support general cancer control. It also has the function that allows to identify in its specific country, as you see here in the map, which organizations and partners are present to support your efforts in implementing, fostering alliances and technical support from leading organizations, including UN agencies as IARC, IAEA, but also global and international partners like St. Jude Children's Research Hospital and the International Society of Pediatric Oncology. The Knowledge Action Portal also, it's a very important tool that allows us to share best practices from countries that have advanced already in the implementation phase of the initiative. And recently, in December 2021, building on the success of the Global Initiative for Childhood Cancer, the WHO and St. Jude announced another major project that would contribute significantly to the achievement of the increasing survival target with the launching of the Global platform to access childhood cancer medicines. Through an investment of $200 million provided by St. Jude, this platform will provide end-to-end support, consolidating demand to shape the market, assisting countries with selection of medicines, developing treatment standards, building information system to track effective care that's being provided, and benefiting approximately 120,000 children with cancer by the year 2027 in at least 50 countries. Currently, 6 countries have been identified through their progress in the implementation of the Global Initiative for Childhood Cancer, 1 in each of the 6 WHO regions that you can see listed here. So currently, after 2 years into the development phase of the global platform to access childhood cancer medicine, the governance structure has been selected. Selecting procurement agencies has also been one of the major steps during this development phase. So we are working in partnership with UNICEF and in the Americas with the PAHO Strategic Fund in preparing now the kickoff phase in these 6 initial countries that are currently performing assessments to understand what are the gaps and the needs in the general supply chain to be able to provide medicines for children with cancer in their countries completely freely of charge. And now to conclude, we can say that significant progress has been achieved in over 70 countries implementing the cure-all approach, elevating childhood cancer to the highest political level. The Global Initiative for Childhood Cancer has demonstrated that improving quality of care and outcomes for children with cancer is achievable, as I mentioned, through broad political commitment, strategic investment, and development of strategic action plans led by government, but supported importantly by multi-sectorial partnership. The initiative is now supplemented by the Global Platform to Access Childhood Cancer Medicines, which seeks to improve free medicines for children with cancer in at least 50 countries by the year 2027. And I thank you very much for your attention and hope to receive some questions through the discussion. Over to you, Partha.
Thank you, Roberta, for this very informative presentation and then highlighting the huge amount of work that has been done within the framework of this particular initiative. Let me see. Okay, the questions are still yet to come, but then let me ask you a question. You know, you mentioned about the very important initiative to improve access to childhood cancer medicines. And then, as I understand that this initiative is in the process of being fully rolled out. Till that happens, what do the countries do at their level to improve access to cancer medicines, especially for childhood cancers?
Thank you, Partha, for this question. As I mentioned, we have seen as the Global Initiative for Childhood Cancer has been implemented and through a health system approach, the delivery of services for children with cancer has improved. This has been a key element to precede those countries that have been selected to access childhood cancer medicines. WHO currently has, as part of the country support that we provide, also outside the structure of the platform, we have been contributing to support procurement requests from country offices. And we align we review this request to make sure that children have access to essential medicines that align with current international standards of care. So that's part of the support that WHO is currently providing outside the platform. But as we mentioned, the platform is a project ongoing, and we hope that by the end of this year, the initial 6 countries will have access, but by next year, we hope that this initiative will scale up to include 2 more countries by WHO region. And that means that as we also stable the market, this will allow also for pool procurement and access medicines at better prices and good quality. That's another important thing. Through the platform, countries, for instance, that did not have all the essential medicines to treat childhood cancer that are included in the essential medicine list will also have the possibility to be regulatory process would be supported, and these medications would be accessible, as we know that in some countries not all the medications are registered, so the platform will potentiate also access to registry and access to medicines. Over to you.
Thank you, Roberta. There is a question, if I understand it correctly, is there any clear criteria to be part of this Cure for All initiative?
Actually, the core projects is a list of interventions, 10 interventions that countries, when they are designing their national action plan for childhood cancer, will select among according to their capacities and their context. So usually the initiative, the process to implement the initiative go through 4 phases. So there's an initial assessment phase where countries understands or provides a snapshot or their current capacity to for service delivery for children with cancer. So through this assessment, they can identify then in the process of planning what among these 10 core projects would be feasible with the resources and the current context. And then, as we mentioned, WHO, working together with partners, is providing support to scale up these capacities. So that allows them to identify which are those areas that are prioritized and how they can scale up in time.
Thank you, Roberta. There is a very interesting question. Is there a childhood cancer early detection and treatment guidelines so far developed?
Yes, at regional level, we have currently been collaborating with our colleagues from the Pan American Health Organization, and there is a strategy for early diagnosis. As we know, most of childhood cancer cannot be prevented as cervical cancer is, but it can be detected early through the strengthening the capacity principally at a primary healthcare level. So at the different, as you have seen through the implementation of these 10 core projects, countries select specific areas they want to strengthen. And when we talk about early diagnosis in childhood cancer, it's not just about raising awareness about warning signs, but also strengthening the capacity for referral. So we're also working from the global level. Recently, WHO has provided a set of indicators aimed at primary healthcare level to evaluate and monitor this capacity for early diagnosis. And also we are still working to provide also these quality indicators for improvement at facility level. But yes, we are working as part of the core projects for the Cure framework.
I can see Nashwa has posted a link on the chat box that is a kind of repository of the WHO publications on different initiatives. Thank you, Nashwa. If there are no more questions, thank you so much, Roberta, for your excellent presentation.
Thank you, Roberta.
We move on to the next in a global initiative, which is Global Breast Cancer Initiative, and we have Dr. Ben Anderson to present the initiative. Ben is a medical officer at the WHO, where he led the development and launch of WHO initiative on Global Breast Cancer Initiative. Dr. Anderson is Professor of Surgery and Global Health Medicine at the University of Washington. As Surgical Director of the University of Washington Breast Health Clinic, Ben has cared for patients with breast health issues and diseases for long years, so starting from 1994. So over to you, Ben.
Thank you very much, Partha. And let me get my slides up and running. Let's see if we can make this work. And if you could verify that you're seeing the screen correctly.
Yes, we can. No problem.
Perfect. So first of all, I'd like to thank the IARC group for including me and my colleagues in this discussion of the 3 initiatives. And so my assignment here is to talk about the Global Breast Cancer Initiative. But before I do that, I want to point out that this triad of these three initiatives sets the framework. They're the three legs of the stool for looking at cancer overall. And because between childhood and its unique challenges and needs focused on treatment, cervical cancer that addresses women's cancers and the infection-associated disease that is, and breast cancer, which is a model for adult cancers, as we'll talk about in this. It gets us prepared for looking at cancer in this very broad global way. And so we'll be walking through the GBCI. GBCI is the most recent of the three initiatives. And so we're in the process of having set this framework and now identifying how do we actually implement and proceed going down the road. So, but I think you have to begin, especially this is summer school, let's think about the questions that what are these issues, because there have been historically major limitations or misconceptions about cancer and what is feasible. And rethinking this is a core aspect of what WHO has been focused on. When we consider breast cancer is now the most diagnosed form of cancer globally. That is actually taking men and women together. It is the leading cause of cancer-related deaths among women worldwide. There are more disability-adjusted life years lost by women globally to breast cancer than any other malignancy. The majority of breast cancer cases and deaths occur in low and middle income countries today. There's been this misconception, which we'll look at the data in a moment, that breast cancer is really just a problem in high income countries. But in fact, the shift has already taken place, and low and middle income countries are where the majority of these take place. In fact, there's a huge disparity and it's worsening. By 2040, 60% of the projected 3 million new breast cancer cases and 70% of the 1 million new deaths annually will occur in low and middle income countries. This data comes directly from IARC and GloboCan and our best projections going forward. Breast cancer 5-year probability, there's this huge range where in high income countries, North America, Western Europe, Australia, the 5-year survival is 90%, but it's 66% in India and 40% in South Africa. So clearly that is a statement of disparity. I think we would turn that around and say, but that's also a statement of opportunity, because it means that we know what to do and we actually are able to achieve it. The question is, how do we translate this, what we know and what has worked, into limited resource environments? If we focus specifically on sub-Saharan Africa, and we now have data, again, thank you, IARC, for this. We have the ABC-DO study, African Breast Cancer Disparities and Outcomes Cohort Study. We know that in these 5 countries, half of breast cancer deaths occur under the age of 50. And that's young, right? And for every 100 of those deaths, as Partha was referring to earlier, 210 children lose their mothers to breast cancer, become maternal orphans. So this is not just an economic and social problem. This is a generational problem. And that's part of the reason we have to think through, how do we really do this? How do we make this happen at the ground level? So here you see the incidence of breast cancer globally, darker meaning higher incidence. And this is what has fed this incorrect assumption that actually breast cancer is really just this problem of high income countries. But remember that in those countries, one of the features of them is we screen. We actively look for these cases of cancer. And when you screen, you find. And in fact, when you screen, numbers go up. I just want to say parenthetically, this is a public health sciences meeting that we're doing in the summer school. We use this term secondary prevention when we talk about screening. And that rationale for that, which is a public health sciences way of thinking about it, is well, we have primary prevention where we try to stop the cancers from occurring. Secondary prevention is, well, if we screen and we find them earlier, we'll do better. So we'll prevent mortality. There's actually a problem with that. And that is that when we screen, the numbers go up, not down. So I'd love it if we stopped using the term secondary prevention. I don't expect anybody to actually listen to what I'm follow because I'm saying it, but it's for the rest of the world, incidence going up doesn't exactly sound like prevention. But if we then turn around and ask ranking, so that was by numbers. If we rank countries, what is number one among breast cancer incidents? Now you see that 86% of countries, breast cancer is the number one diagnosed cancer among women. So this is a more realistic understanding of how the incidence works globally. Now, when we turn around and look at mortality, so the darker colors are higher rates of mortality, we see that the sub-Saharan African countries is dominated by these very high rates of mortality. It looks very different when we look at absolute numbers. But again, if we go to that ranking, so countries looking at it as a group, here we see that 95% of countries, breast is number one or number two in terms of female malignancy deaths, cervical being the other one that goes with this. And so really the point here is no Ministry of Health can overlook breast cancer if they intend to address cancer as a significant public health issue in their country. So you can't skip this one, it's too big. And therefore it's actually an opportunity, but that was not what people said 20 years ago. 20 years ago, people said, well, you're kind of lucky to live in a country where breast cancer is a problem. And that myth was never true, but is commonly said even today. So we need to rethink these questions. We need to rethink how we're going to do this. And as this group is well aware, one of the pieces we have to think about are guidelines. But most of the guidelines that had been developed in the past were scientific exercises about how do we do cancer if you have all the resources. It's a very important scientific question. This is where NCCN and ASCO and ESMO focused, but they fundamentally don't apply alone in low and middle income countries because they have some but not all of the resources. If that's the case, then what does apply? What is it that we should be thinking about? And therefore, what adaptations are required when some but not all of the standard care resources are available? What features of healthcare systems characterize meaningful potential for improving breast cancer outcomes and more broadly for women's health? And to just speak frankly, the question is meaningful improvements even possible? Or are we really just we're saying platitudes that aren't really true? I do not believe that to be true. I do believe that there are opportunities here, but we have to think the questions differently. While I said that the Global Breast Cancer Initiative was the most recent of the three initiatives, it's not because the thinking started recently. We actually have a 20-year experience of work that came before the Global Breast Cancer Initiative that we'll talk about next. So here is this concept of resource stratification. The prior group that I worked with called the Breast Health Global Initiative based at the University of Washington and Fred Hutchinson Cancer Research Center. This group was responsible for developing these concepts of resource stratification. So I'm now speaking on behalf of the prior group and acknowledging the tremendous support that came from this, from the Fred Hutchinson Cancer Research Center and Susan G. Komen Foundation. And what we did in this structure, we asking this question, what is it that would work in low and middle income countries? We held a series of global summits, bringing together experts from high income and low income and middle income countries to ask these questions collectively. And it was that second global summit where we focused on this idea of resource stratification. And that's the point I want to bring out to this group, because this was an important predecessor of what has led to the Global Breast Cancer Initiative. As I referred to earlier, when we had our first global summit, the response was, that's really nice, you people in Seattle, and you're clearly well-intended, but if, some countries are so poor that breast cancer is not a significant problem for them. That was one of the challenges that we received. And what we concluded from that was, well, actually, that leads to a really important question, which is, at what point are resources so limited and competing demands so great that breast cancer programs make no sense to create? We went to Ghana, West Africa in October of 2004 to ask this question. Ghana is now a lower middle income country. It actually had been below the line, but they've made wonderful progress in their own work. And they are, I cannot say enough about how wonderful Ghanaians are and how inspirational I find this. This is the Komfa Enoche Teaching Hospital in Kumasi, which is the second largest city in Ghana. And this is the multidisciplinary clinic that they had in their breast center. So the experts meet and we talk about multidisciplinary care. How do you bring together surgery, radiotherapy, and drug therapy in the most effective ways? The gentleman closest to us in this picture was the one pathologist for this 1,000-bed hospital. It had a dental school, a nursing school, a medical school, and one pathologist. And the reason they only had one pathologist was because the prior thinking had been about infectious disease, and pathology doesn't play the same role in that it does in cancer, where it's absolutely essential. And the lady to his right was the one radiologist for this facility. When we're talking about pathology, if you looked at the country of Ghana, how many pathologists might they need? They would need somewhere around 115 for standard pathology. The country had 3. So there is an example of a tremendous need, but it impacted in ways that got us thinking about this resource stratification. So one problem was advanced cancer stage of diagnosis. We've been hearing about that in terms of the other initiatives. They would do treatment we did what we could do. And so what would happen is that patients would come in, they would see a surgeon, and the surgeon would do a mastectomy because that's what they knew how to do. And this goes back historically to the use of the radical mastectomy as being this mainstay of how we manage cancers. But they weren't getting the drug therapy or radiotherapy. And as a result, it's very predictable from a biological perspective. If you just do surgery, you will not prevent the metastatic disease from forming and progressing. That's the drug therapy that does that. And so therefore, we have to rethink this. You'd ask the women, why do you not come into the hospital? They'd say, why would you come into the hospital? They just cut off your breast and you'll be dead in 2 years. And in fact, the system was making it true. But back to the pathologist, one pathologist for a 1,000-bed hospital meant that a pathology report would typically take 4 to 6 months to generate. And if that's the case, if you can't prove that it's cancer within 4 to 6 months, how can you effectively do therapy? That was this key point that got us to this idea of resource stratification. And that is, we can take the resources and we can put them in a priority order to make systems that are functional. And a basic level resource is one that you cannot do without. If you don't have this resource, you probably should fast forward to supportive and palliative care. And then having this tiered structure beyond that. This is not just a 1, 2, 3, 4. These are specific definitions of what it is that one is to do. And then we, in a comprehensive system-based fashion, looked at with those four tiers, health systems, early detection, diagnosis, and treatment by stage. And these are all standard tools. This is not something new and radically different and biological and super expensive. These are standard tools. We were first, when we did this idea of resource stratification, we were critiqued for this. And they said, well, wait a second, aren't you just certifying substandard care if you do this? And you're saying it's okay to do less. That is not the concept of resource stratification. The concept of resource stratification is that you need to go in steps. And what you want to do is make sure that you're making the right next step and not fast forwarding to something that's too large of a gap to be effective. So resource stratification is not a certification of substandard care. It is a method to identify evidence-based pathways for sustainable, that is a critical issue, stepwise improvement adapted to existing resources. If someone goes into a country and you do an intervention, if you leave and the project stops, if it does not continue, that is the definition of failure. So a successful program is one that continues beyond whatever the intervention is that you did. So WHO has adopted resource stratified guidance, as Roberta was talking about, and accepted the role of global partnership in cancer management. There is no single group that can do this alone. We have to work collectively. And therefore, evidence-based resource adaptation can provide a framework for health system strengthening using breast cancer as a model. So as I was referring to earlier, The reason you do breast cancer is not a siloed reason. It's not just because it's big. It's because if you can do breast cancer, there are a lot of cancers that you can do. And because it's the most common cancer, we have a tremendous amount of evidence that tells us what the impact will be of different interventions. So now we have this resolution from 2017 that Roberta's already referred to about developing and adapting stepwise and resource stratified guidance and toolkits in order to establish and implement this comprehensive care. So it was the 2017 initiative that got this forward. If you're not familiar with WHO, WHO is a policy organization, and it is driven by what are our initiatives? Are we called to do based upon resolutions? And that is our marching orders, and that's why I'm here today. So now we need to think about what are paradigms for change? How are we going to modify this in evidence-based ways? And this is the formation of the Global Breast Cancer Initiative. The document on the left is our framework document. We spent 2 years putting together this evidence, being informed by, but not limited to, the Global Breast Cancer Initiative. And earlier this year, we published this implementation framework, which describes how one would address this cancer issue. The objective is to reduce breast cancer mortality by 2.5% per year, because that would avoid 2.5 million breast cancer deaths globally by the year 2040. You will note, while the Sustainable Development Goals talk about 2030, when we talk about cancer, you have to think of longer term strategies, because it's like the Queen Mary cannot just hang a left. It takes a while to see the impact. But what you're looking at here on the bottom, those are on the left side are the mortality curves of 10 countries, most of which are high income countries. But what we see occurred was that between 1990 and 2020, there was a 40% reduction in breast cancer mortality. This is a tremendous success. The question then becomes, how do we translate what happened in those countries, which occurred with tools that we would all consider standard today? How do we translate that to countries that have not yet seen the benefit? And the thesis is that we're using the patient pathway, clinical management, because this is in fact how it occurred in high-income countries. And we divide this into 3 pillars. The first is the pre-diagnostic interval, where we sort out how do we get the woman walking in the door with reasonably early stage disease. That's early detection target. The second pillar is the diagnostics. How do you prove who has cancer and who does not? This pillar was generally overlooked. People talked about prevention and maybe this early detection, and then they talked about treatment, and they missed the part in the middle about somewhere you have to sort out who has cancer and who does not. And we'll talk also about this in a little bit greater length in a bit. And then that third pillar of treatment, how do you manage these cancers in ways that are appropriate and effective? So the first pillar is the health promotion for early detection. And so the woman enters the system, and either because she has undergone screening, and that's what we tend to argue about the most in high-income countries, what age do you start mammographic screening? Like, that was the big question. It actually is not the big question. Or they enter with symptoms. And that means they come in with a lump or a finding. And what we want them to do is come in when the findings are early. That's called early diagnosis. And the idea of doing clinical assessment, that being able to manage cancers that you can feel or see, this is essential to what we do. If you cannot manage the cancers that you can see and feel, you're certainly not ready to have a system where the only way you can see the cancer is on an image study, but you can't feel it and you have to be able to sample it. But the idea is, so they enter the system, and our target is for 60% of the invasive breast cancers to be stage 1 or 2 at diagnosis. And so how are we going to do this? Health literacy. The public needs to understand what is cancer, why would I come in early, and what is it that I'm looking for? And we want to link to other activities. So if in cervical cancer, the recommendation is to do cervical cancer screening in the ages 30 to 49. Well, let's link this to health literacy so that the women would understand breast cancer too. We have to not think in siloed ways. This is a current conversation between the Cervical Cancer Elimination Initiative and the Global Breast Cancer Initiative. But the education also has to occur with providers. if a provider is in a system where they've actually never seen an early cancer, they're likely not to recognize it. And so for the providers to understand that subtle lump may be a cancer and it does need a diagnostic workup, we have to create educational modules so that they're familiar with it adequately and not send the patient away thinking, well, it's probably an infection, let's give them antibiotic. And we need to have that training then about doing this clinical breast assessment. This is very fundamental. And in high-income countries, as a surgeon, if you trained as a general surgeon, you learned all this. This was all basic stuff. But if you haven't been in an environment, well, that's going to be an issue. But what about that target of 60% of invasive cancers? Partha asked this question earlier. Where did this number come from? We did an analysis, published it in October of 2021, where we looked at what are the features of health systems associated with that reduced breast cancer mortality. Data collection is a big issue because there isn't the data available in the limited resource settings that we need. But we were able to identify 35 countries that had adequate data on both mortality statistics and stage distribution that we could make a comparison. And what we found was that 20 of the countries had that sustained mortality reduction, that dropping mortality of better than 2% per year over a three sequential years. 15 did not. And we asked the question, what was the difference in stage distribution? It was every country that has reduced breast cancer mortality had at least 60% stage 1 or 2 cancers. Conversely, we have found no country that failed to cross that threshold and has had that sustained mortality reduction. This is really important from a ministry perspective, because talking about mammography, like that's the big question. And then countries go out and buy mammography equipment. We didn't actually explain that, well, actually, it's not the mammogram. That's the easy part, is getting the mammogram. It's the whole system that makes mammographic screening work. It's getting them back every 2 years. So you go from a negative mammogram to a positive mammogram. That's how mammography really works. And that means you have to track the patients. You have to be able to follow them over time. This is hard. If you ask what countries of middle income have successfully set up mammographic screening programs, the answer is, I don't have an example. So Jordan started a mammographic screening program in 2006. Georgia, the country in Eastern Europe, had started their program in 2008. Neither have population-based screening mammography programs established. And that's on us. We didn't explain adequately what it was that they were supposed to do. So now this takes us to that second pillar, this diagnostic part that we were referring to earlier, that how do we, now that somebody presents with a finding, what are we going to do to sort out who has cancer and who does not? If you look at if you look at clinical exam, for 10 individuals coming in with a palpable lump, 1 will have cancer, 9 will not. And we need to sort out who is who in that reasonable period of time with imaging, tissue sampling, and pathology. If we get a benign diagnosis, then we're done, other than to follow up to make sure that it's not behaving in a way that seems different from what we learned, or a cancer diagnosis. And those are the ones that are navigated on for treatment. The target here, the key performance indicator, is to make a diagnosis within 60 days. So here we are. How are we going to do this? That having rapid diagnostic units where the woman comes in and she can have a diagnosis, these are standard tools. So ultrasound in Rwanda, a pathology lab in Ghana, these are pieces that need to be set up. And sometimes there may be a role for leapfrog technology. So rather than just saying whatever it is we did in the high-income country, maybe we can use special technology that hasn't been developed yet, in the same way that cell phones really pushed this forward without having to develop landlines around the globe. Can we use leapfrog technology, such as PCR, instead of the more difficult technology to get the pathology? These are some of our important questions. Patient navigation is among the most important topics. How do we get the patient through the system without redundancy? Many settings where a woman might have 5 or 6 clinic visits before someone says, say, that might be cancer. We need to have these navigation systems set up and running. But where did that 60-day period? Why did we come up with that? A systematic survey was done back in 1999. That sounds like ancient history, but actually that's with all the tools that today would be standard in low and middle income countries. 87 of them had data, 5 category 1 of which 38 had adequate data to look at 5-year survival rates in association with delay. Delays greater than 3 months overall had a 12% lower 5-year survival. If it was only 3 to 6 months, it was a 7% lower survival. So the reason we picked 2 months is that by 3 months, that's when we see mortality starting to increase, survival to start to drift down. So we want to make a diagnosis within 2 months so we can start treatment in 3 months. Indeed, Brazil has now passed a law saying one must make a diagnosis and start treatment within 60 days. This is a nice linkage between evidence and policy. Now, if you ask, did the passing of the law change the data? Not yet. And so we have to move into implementation and think this through further. This third pillar is that treatment. And we know a lot about how to treat breast cancer. Early, I'm actually in Chicago at the moment at the American Society of Clinical Oncology meeting. And this is what is, this 35,000 people are here in Chicago talking about this. And breast cancer is probably the most discussed cancer. So how to manage this with multidisciplinary management and using the systemic surgery and radiotherapy. And let us not forget supportive services. That how do you support the patient through this? This is not just hand-holding. This is how do you give, what are the medicines that you need to make chemotherapy tolerable? If you don't give this, the patient won't, may well not complete their therapy. So the key performance indicator that we've selected is 80% of patients undergoing multimodality treatment without abandonment, meaning that they are completing their treatment all the way through. So this is timely multidisciplinary care, patient navigation, measuring your outcomes. Here we are at summer school. If you don't measure your outcomes, even if you're doing everything perfectly, you won't be able to prove that what you did worked. So thinking with an implementation science framework is essential. But we don't forget about the woman after. We have to think of what happens when she reintegrates with the community. What about financial toxicity? What about stigma? How is this all going to be managed? Are those patients going to get the support services that they need, including survivorship and palliative care for those that need end-of-life care? So this 80%, here is that ABC-DO data that we were talking about from IARC. And the summary graph on the lower right shows you how many patients actually followed through. Of those patients who started treatment within 3 months, fewer than 50% completed their therapy. That is the worst of all worlds. That means you got the side effects from your treatment, but you didn't get the clinical benefit because you have to do the entire protocol in order to achieve that. And therefore, you wasted the medications that were there. This is another example of a topic we don't talk about. We've been talking about procurement of the drugs. Did you get the drug into the country? But we now need to ask, is the drug then getting into the arm of the correct patient and for its full duration? That's why it's this key performance indicator. ABC-DO data shows that if we follow those 3 pillars in sub-Saharan Africa, the blue bars are current 3-year survival, and it's not good when you look at these different countries. This shows the heterogeneity within sub-Saharan Africa, but the colored bars show how much it would be improved if we were able to address our 3 pillars. And so we have every reason to believe that this is doable. And there are things we can do. We just have to think from a resource stratification, building health systems, building approach and prioritize correctly. So then that gets us to this next question of strategic implementation. How are we going to do this? And this is the point where the Global Breast Cancer Initiative is now. So we have the 3 pillars and we have strategies for each of the 3. Training and capacity building, data collection. We must link to data systems that exist or create additional data if they don't exist, but let's use what we have. That's a sustainability concept. And facilitation of care, and that takes everybody coming together into the field. And so training courses and working with models such as DHIS, patient navigation programs, these all are going to be designed to do this. This is the next phase for the Global Breast Cancer Initiative. But then how are we going to measure our impact? How are we going to assess those outcomes? Well, when we establish programs, how do you begin? Well, you begin with demand creation. How do you awareness campaigns, working with community groups? Again, that education and engagement of the public is essential. You have to have that training so that once you've raised awareness, there is a place to send patients to get the services that they need. The service delivery needs to be done. We are looking here at a programming for Kenya. And this was a very nice project that was funded by the World Bank and was performed by RTI International in collaboration with WHO. And considering this monitoring and evaluation framework, this is really essential that we do what we're doing here. Here is the projections for Kenya. And this gets to that point about secondary prevention that I was talking about earlier. So 31% of breast cancers today in Kenya are early stage disease. If they just get set up so that in the first 5 years, and you can't, even if you have the money, you can't snap your fingers and make this happen. In that first 5 years, as you're building up, the stage distribution will improve. This is called stage shifting, but the number goes up. In fact, if you look at the number of cancers that would be need treatment in Kenya, it will approximately double. And so the ministries need to know this. When you start these early detection pieces, your other demands are going to increase. They're not going to be flat or stable. And then we look to early detection strategies. What happens after that first 5 years? We're ready to receive the patients. Do we screen them with mammography, which of course is this dominant conversation? If people have questions, we could talk about that later. And that will definitely get you across the line. But it turns out we now have evidence from Mumbai, India, that shows that, in fact, and actually 2 studies, of which Partha is a driver of one of the 2, that shows that clinical detection using, we talk about clinical breast exam, but it's really clinical assessment. It's a history and physical, which is a pretty old-fashioned concept in medicine. That can get you across this 60% line. And the Mumbai data suggests that actually you see a mortality benefit in women 50 and above, meaning that in that study, we were able to get the treatment in to achieve the benefit of crossing that line. But as you can see here, this is a framework. This is a way that we're going to think about this. From the ministry standpoint, they need to know how much is this going to cost. And so being able to project this is another aspect of what WHO is working on, which is project tools that help us project where we're going to be going forward. So in summary then, breast cancer, it's an index malignancy for organizing health systems. It provides this framework for resource appropriate early detection, diagnosis, and treatment by stage. If I was going to draw an analogy for what are we doing here, this is the chessboard. We can talk about chess. We can talk about how does the bishop move, how does the queen move, and think in that siloed way, but you actually need the chessboard to start to play a game. And that it's the same idea here. That's what we're doing with the GBCI pillars and key performance indicators, this framework for health systems to define a roadmap for stepwise and essential point sustainable improvements. We cannot use a philanthropy model in adult cancers to make this go over time. Different from what the amazing work that St. Jude and the Childhood Initiative have done in terms of addressing childhood cancer, we have to have sustainable improvements that are coming from within the countries. That's the only way it can work. GBCI monitoring and evaluation frameworks, it's a tool because we need to know if those key performance indicators are not right, what's the root cause? And how is why are we getting this underperformance in these areas? Because finding out that things are bad isn't enough. You have to then go on to, and what were the solutions that would make predictable improvements? As such, impact modeling informs the ministry about anticipated costs and outcomes so that they can make their decisions. Are we going to invest in this? And ultimately then, the Global Breast Cancer Initiative can be a catalyst for change by developing approaches that are relevant to women's cancers and women's health throughout the life continuum. With that, I will close and thank you for your attention. Be happy to address any questions that might come up. Thank you again.
Thank you so much, Ben, for this wonderful presentation. There are already questions in the chat box. And the first one is what you already referred to about breaking the silos and bringing in integration between the different initiatives. So Dr. Ishak Lawal has commented, and then his question is the Global Breast Cancer Initiative considering integration of breast cancer early detection strategy into cervical cancer screening program?
Well, that is a really great question and a very current hot topic that we're working to address. And because for a long time, people have been saying, well, can't we just talk about women's cancers? You know, women have both breasts and cervices, and they don't really care about how we silo our work. We talk about breast versus cervical because that's the medical system organization. That's how our care is developed. But there are fundamental differences between breast and cervical, and we need to break out which is which. So, for example, the prevention strategies that are so effective and powerful in the Cervical Cancer Elimination Initiative with HPV testing and vaccination, we don't have an analog for that in breast that is functional. The analog of doing a LEAP procedure in cervical cancer would be a bilateral mastectomy, but that is not an acceptable alternative for the large fraction of women. So there's a lot more you can do at a primary care level with cervical cancer. And whereas in breast, you have to think of these three levels, that diagnostic piece, cervical needs that for the cancers to become established. So we're now currently working with this idea of, in the framework, how are they similar? How are they different? And then how can we functionally integrate that in ways that from a system standpoint works? But we've been talking about breast and cervical as, you know, like two taglines for quite some time. We have not yet made progress in this. This is what I think is one of the great strengths of having these three cancer initiatives linked. We can compare notes. We can talk about where we integrate to make these functional systems. And it's all about health system strengthening. Because keep in mind, everything that we said about cancer applies to other non-communicable diseases as well. So it's a really fundamental strategy using things we already know about that are effective.
Thanks, Ben. There is a question from Subita Patil. She's asking, can you please explain patient navigation across primary, secondary, and tertiary levels of care? Is there any guideline or standard protocol for patient navigation?
So I super love that question. Thank you very much for asking that, because that's actually the next thing that we're working on. People talk about navigation, and it's been you kind of need a navigator to help patients through this, but we realize that you need formal navigation, understanding, and structure. And GBCI is a good place to think about it, because each pillar requires navigation, but they're different in terms of the skill set and the requirements for them. So, the idea of navigation is just because we put up a map doesn't mean you're going to be able to get there. If you're sailing in a boat, you need a navigator that will allow you. And this is all about the patient pathway. So a navigator is someone who facilitates navigation. If you're talking about somebody who's coming in with a new lump or finding, having a lay navigator that can help you identify where's the place that you're supposed to go is really ideal. And if they're a cancer survivor and have been through this, boy, think of the power of that. But then we have to navigate them within the system. Now I've made it to my diagnostic unit. How do I make sure that they get all the tests that they need? And then for the 1 out of 10 cancers, how do they get to the cancer center? And then how do they get navigated through treatment? That's going to require a professional level of navigation and a professional level of understanding this to help the patients get through this. We have implementation research that is showing benefit to navigation. Completion of therapy. Navigation has survival benefit associated with it. We need more studies to do this. But so our next project in the Global Breast Cancer Initiative is to describe what's navigation, how does it work in the three pillars, and what are those types? Lay navigation, professional navigation, and then let's not forget about virtual navigation. What if I had a cell phone that gave my smartphone news about here's where you're supposed to go and here's why you're supposed to go there? Will that help? Or do you actually need a person that can explain this? These are the sorts of studies that would have tremendous impact, and we're at the beginning of where this is going to go. I'm hoping that explains the navigation concept.
Thanks, Ben. There is a comment from Subhadra Gwala that task shifting through training the training the community health workers to perform clinical breast examination is useful, but her own experience says that it is quite challenging to implement in real health setting. I believe talking about Indian context, and where the CHWs are overloaded with a lot of different programs.
So the point about clinical breast exam is a really good one. So as a surgeon, I directed the breast health clinic for 20 years at the University of Washington, and getting clinicians to the point that they're comfortable with breast exam, that you do an exam and you have a sense of, is that a lump? Is that not a lump? That it takes experience to do that. We would estimate 500 cases that before you really started to get it. And in fact, it's not just doing the exam. You need to do the exam and then you go, I think that might be a finding. And then you send them off for a diagnostic workup. And then you need to get the information back to find out, was it a cancer, was it not? Because if we don't give feedback to the provider, how are they going to get better at what they do? So that how to build systems. This is actually in mammography, the BI-RAD system. That's what it's all about. You make an assessment, you get the answer to the question, and it helps you learn and improve what you're doing. So how could we accelerate this clinical breast assessment? One of the needs is to set up those diagnostic units so that there are providers that do this on a regular basis and know what it is that they're supposed to do. But maybe there will be tools that would help us. So there, as an example, there is a tool called the iBreast, and it is a technical device that helps give you live feedback about what you might feel on an exam. Some evidence suggests that may accelerate your ability to learn clinical breast assessment. But it again gets me back to this idea of implementation research. What works in India might be very different from what works in Shanghai. And in fact, it needs to be specific to the environment. And so that's why we want to do these studies to figure out what worked, and what worked in one place may be different from another. But we're trying to be catalytic here, which is we're going to collate this information of what worked and what didn't, and what are those elements, so that we can all these countries can move together from where they have been to where they're going.
Thanks, Ben. Next question is from Hassad Ali Fernando's about primary prevention of breast cancer. So if you can say a few words about controlling risk factors and then preventing breast cancer.
Absolutely. So primary prevention means stopping the cancer from occurring in the first place. And it is unarguable that that's the best strategy. If we could stop it from happening in the first place, that's delightful. And that is, in fact, if you go back to the early 2000s, that's where WHO was they talked about primary prevention. They didn't talk a lot about treatment. And I think there probably were multiple reasons, one of which was they thought that must be impossible and we can't really do that. So let's talk about primary prevention. And I just want to say that thinking of you can't really get there from here, it is a pessimistic thought, but I also would like to point out that was the same point that was made about HIV in Africa in the 1990s, which is you can't really get there from here. And we proved that was wrong. And so we have to be thinking in this way that is positive and optimistic as we go forward. Gosh, Partha, I'm so sorry. The question. Oh, primary prevention. Thank you. So in primary prevention, there are risk factors that we know about. So most of them have to do with reproductive activity and for postmenopausal breast cancer. So did you start your periods earlier? Did they go later? When did you have this first childbirth? Uninterrupted cycling. That seems to be a common biological theme. And so on the one hand, that tells you about breast cancer, and it gives you biological insights into this. But the preventive benefit of getting earlier pregnancies is not a large number. It takes thousands of women to be able to see a benefit in earlier pregnancy. This is not a reason to go out and get pregnant. And you have to think broadly about, do we want to encourage teen pregnancy to prevent breast cancer? Clearly not. So what we can intervene on is a part of this. The number one, the two risk factors that are ones where interventions could be done are alcohol intake and obesity. And now impacting on obesity is not a trivial matter. And we all know you're supposed to be physically healthy and maintain body weight. There's nothing easy about that. And the idea that everyone will suddenly become physically fit is probably not a realistic public health sciences perspective. Alcohol is the number one. About 5% of breast cancers globally are attributable to alcohol consumption. So if there's one message to get, it would be however much you drink, less is better. And if you stop drinking, that would be the best of all. And there's a whole bunch of health reasons that would be true. But if 5% of breast cancers are attributable to alcohol, that means 95% are not. And if you asked, if everybody did everything right, what fraction of breast cancers would be prevented? It's maybe 20%. So 80% are still going to occur. That's why we still have to think about, it's not an argument against primary prevention, that all the reasons that you are well aware of, we want to talk about those, but we still have to think about the early detection, diagnosis, and treatment to address the majority of breast cancers that will still continue to occur.
Thank you. Europe is taking steps to introduce cautionary messages on the bottles of alcohol. Hopefully that will. There is a question that I'm sure you'd love it. It's from Patrick Edoko. What is your advice for breast cancer screening in a country without any mammography service? Invest in mammography or train healthcare providers to perform regular clinical breast examinations as part of routine services for women?
So you're absolutely right. I love that question. And because I think we've been asking the question poorly for a long time. The high-income countries got into this humongous debate of when do you start mammographic screening? And the debate continues to today. So do you start at 40? Do you start at 45? Do you start at 50 if you have mammographic services? And the high-income countries were duking this out to the point that you could make the argument on either side. It's the glass is half empty or half full. And where do you make this cutoff is, it's not that hard to, let me make argument A and then I'll make argument B and they sound different. The main point to address here is that is not the first question. In the tiers of basic, limited, enhanced, mammographic screening is at the enhanced level because of the resource demands that are there. And to the point of the question, you have to be able to do the clinical detection part before the mammographic screening is even a relevant question. And so it's a prerequisite. If you can't manage the cancers you can see and feel, you certainly can't do the ones that are only going to be seen on imaging. But even when you have a screening program, even when that's the case, about half of cancers will present clinically anyway, either because the patient was too young, they were out of the screening age group, or because the cancer is showing up between mammograms. So again, that's the latter part of setting up clinical assessment that must take place. Mammographic screening, that I showed you the data about Kenya, and you say, well, what does it take to do this? And it's a lot, because there's the equipment, there's the data resources, and there's the workforce. If you look in Kenya and said, if you did mammographic screening 40 years down the road, how much of your programming would have been on that mammographic screening? It's over a third of the entire program. So that's one of the reasons to say it's an important question for countries to decide. We have to do clinical assessment? Do we add mammographic screening? And if so, where? Do we just do it in cities? What about rural areas? How do we think this through? Countries are going to have to make that decision. So giving them good data about, if you make this mammographic screening leap, what are you actually leaping into? That's an important part of what we do. And it is not an easy on-off question. If the country does not have mammographic screening and you're back where Kenya was, then no, mammographic screening, mammography plays a role in diagnosis. It's a diagnostic tool, but actually breast ultrasound is the diagnostic imaging tool of necessity. But if for those that are not clinicians, ultrasound, you hold the probe at, here's this thing that I feel or I can see on a mammogram, and I can characterize it and decide, does that need a biopsy? Is it a cyst? Is it a fluid pocket? I don't have to worry. And I can even guide a needle into this. And it's kind of amazing to me that we've been having these discussions about mammography like that was the first tool, but anybody in clinical medicine knows, no, the first tool is ultrasound. And how often do we hear people talk about this? This is we're trying to change the questions. So the people are asking the functional questions as opposed to the hypothetical ones that assumes the healthcare system is already fully developed.
So Ben, next to that, obviously the question comes is what is the role of breast self-examination?
Great question. And a huge misconception. All right. So back in 2002, it happened to be the same week as our very first global summit. The Shanghai self-exam trial was published. This was a randomized trial that happened to come out of the Fred Hutchinson Cancer Research Center. David Thomas was the program lead. So over a 10-year period, they randomly, using cluster randomization, they either trained women in self-exam in Shanghai in the textile factories, or they had a control intervention, was like a video on low back pain, but they weren't trained formally in clinical exam. And what the study found was that the women trained in self-exam the mortality of breast cancer was the same between the control and the intervention, but there was more benign biopsies in those that were trained. And so the 8-second soundbite that resulted from that is self-exam doesn't work. That is not what the study showed at all. What the study showed was that in Shanghai, training in self-exam did not improve outcome. But what was overlooked in that study was how the control group did. Actually, the women not trained in self-exam, 40% of the cancers were smaller than 2 centimeters. The women were already good at finding the cancers before they went into it. So in retrospect, that study would have been better if it had been done in Mumbai rather than Shanghai. And there may be differences in Asian populations for reasons that we don't yet understand in their capacity for detecting cancers. We don't know the answer to that. But to a clinician, the idea of, well, the woman has no idea what her body feels like. That's sort of like saying, well, if I'm skiing and I take a fall and I break my leg, I didn't need a training course to know there's something really wrong with my leg. And so what we do need to encourage is we changed terminology and said what you want is awareness. You want women to be familiar with their bodies, and doing self-exam is part of that. Knowing what does my breast feel like, and if you have a social environment where that's a taboo, that's a problem. And that's something you want to be thinking through in this environment. And we also need to remember that this is linked to the question that you just asked, that clinical breast exam, we've talked about it narrowly, like it's this test, it's a tool, it's a component of clinical breast assessment. But we have a study that we published back in Peru, and the study in Peru showed that women that had a prior clinical breast exam, 93% of the women who got diagnosed with cancer found their own cancer. So the idea that they're not finding them, they're absolutely finding them. And in most of the world, that's where it came from, her or her partner in some way. And she's coming in with a symptom. But of those women that had a prior clinical exam, those women were more likely to have the cancer, the less delay and earlier stage disease. So you see, when we do a clinical breast exam, there's an educational component to this. You're giving the idea to the woman, what is it that you're examining for? So that when she does this and she goes in the shower, say, what is this? That's beneficial. So we threw out all of those shower cards that everybody had in their shower about how do you do a self-exam. I think we should actually be bringing the shower cards back, because it's not about the test. It's about the woman understanding what is normal for me, and therefore say this is new and different. That is the goal. And that's what we should be emphasizing in that self-exam component.
In the form of breast awareness. Then, there are quite a few questions, Ben. I think we will have to stop, and then we take the last one, which is quite a common question that is asked, especially in LMICs. The question is, okay, in my country, the cancers are seen mostly in young women. So shouldn't we start the screening at a younger age? So the question is when to start screening.
So it is a great question. And so historically, the expert groups have fought about this tooth and nail, and that's what sort of dominated the space. And the U.S. Preventive Services Task Force just came out with a new announcement that they said they were the ones that had said wait till 50, and the clinical groups that are familiar with that do this and said start at 40. We did a group at IARC again. Thank you, IARC held a marvelous group in 2014 where the data was analyzed about what do we know. And the evidence for mortality benefit in 50 to 69 is very clear, and there'll always be an outlier, but the vast majority of groups agrees that yes, there's mortality benefit. The data is more limited for 45 to 50, and the data is really limited for 40 to 45. And so the point here is people said, well, shouldn't you do the mammograms? Shouldn't we start earlier if my population is younger? But here's the problem. Just because your population is younger doesn't make mammography work better. And the problem with mammograms, while there is huge variation among women, dense breasts are hard to image. And it's very common that you'll find a palpable lump that doesn't show up in the mammogram. You use the ultrasound, you go, there really is a cancer here that the mammogram didn't show. So, but if you start and the U.S. Preventative Service Task Force, I was fascinated that they came out with this new recommendation because there's no new, they're sort of saying there's no new data, but I think what mostly changed were the people on the committee. And they were more favorable to this earlier detection side, and that's why they said 40. And I'm not opposed to 40 at all. But remember, in a limited resource environment, the cancers, most of the cancers in the population are in the 50s and above. If you start a mammographic screening program, we've seen it multiple times, your average age will rise because you will find more of those postmenopausal breast cancers that had been occult before. And as we do better with other diseases, more are going to live to the point that that cancer becomes clinically apparent and ultimately takes their life. So if you start at 40 to 45 or start at age 40, you're going to have to screen a very large number of women. If you start at, for example, in the 40s, if you screen 1,000 women with cancer, 150 are going to need a workup, and you may find 5 cancers, 1,000 down to 5. Think of the resources that you had to develop to find those 5 cancers. My argument is not against mammography. My point is that the resource investment that it takes to do that, that's why it's not the starting point. And if you can get halfway there or 3/4 of the way there with clinical assessment, and you needed it anyway, that's the reason to do it. It's not a scientific mammography question. It's a public health sciences resource policy question. And those are not the same thing. They're related but different.
Thanks so much, Ben. I think it is time for us to wrap up the session. I thank all the 3 presenters for their excellent presentation and then the discussion. Those who are attending the summer school, the on-site training program, certainly they will get more opportunities to interact and then ask the more questions about these initiatives. But then it's time for us to end the session, and I hand over to who's going to be this.
Me, Sandrine.
Oh, okay.
Thank you very much, Partha.
Okay.
It's great,
Thank you,
great sharing performance. And thank you to our guest speakers today, Dr. Nashwa Skaik, Roberta Ortiz, and Dr. Ben Anderson. Thanks for all the questions from our participants and viewers on YouTube. And the next event and also next session for our participants will be on Wednesday, same time, on alcohol and tobacco, the 2 devils of public health. So see you then. Thank you. Bye-bye. See you soon.
Very much.